emailed her. She had emailed us all saying that she was out, and I said, try back again. And that's
Okay.
what I just did.
Yeah, I think we're coming back online. LinkedIn is usually a little bit late. Um, okay, looks like we're back on YouTube. I just got a notification there. Actually, we're back on live on LinkedIn. Folks on LinkedIn or YouTube, wherever you're watching. Hey, look, it's not us, guys. I don't know what happened, but we're not even going to be able to begin to troubleshoot it at this moment as to what happened. But we were in a very vibrant discussion about how to maximize virtual care as well as AI in nursing. And I think we did a good job talking about virtual care. I do want to delve into the AI before we finish out the hour. And again, we apologize for any of the technical difficulties. Sometimes they're just beyond our control. But let's talk about the AI if you don't mind. So, who would like to take that topic first about the AI?
I would be happy to start.
Okay, sure.
I alluded to it just a little bit when we began. But there are some companies out there now that really do a great job with this. They are a platform that lies over the top of all of the.
I hear you. You sound fine. You're good.
In that organization, they have the data right before them, and instead of them having to really sift through all different types of documents, they're able to see that this patient may have the early symptoms and signs and of whatever disease process it might be. I'm going to just use oncology in this case, of cancer, and then be able to immediately get that patient to be seen or have some additional tests that might not have been within the aggregate data that they had. And earlier detection is happening. And I know that HCA, which is a major corporation out there of healthcare organizations, has been doing some wonderful work in getting their patients earlier detected, earlier intervention, and actually saving them both time and money in terms of the management and the care of that patient. So just really makes a huge difference for those who used to do this manually. And what it has done is it has saved 70% of the time of the case manager, the nurse case manager, in being able to gather all those data points and bring them forward and use them effectively.
Wow, that sounds powerful, and I'm curious to see what our audience thinks about that. And they seem to be quite happy as well. That's good. And so, Julia, from your perspective, have you seen any effects from utilization of AI in the acute care setting in your facility, or perhaps your colleagues?
Yes. So in my prior facility, there was a data mining, and it did some of the same things that Rhonda is referencing. It was plucking pieces of data and telling a story about the patient's condition of their kidneys or the condition of their lungs, et cetera, et cetera. And so it's really exciting when you're able to mine that kind of data out of the medical record. What I think a lot of hospitals face is the dollars needed to develop that kind of infrastructure and intelligence to their medical record. It's not an insignificant, investment, and it is something that is very costly. I think it will be exciting when we are able to take some of this very thing to the next level and really have like grant funding and government funding that really takes all hospitals to that same kind of infrastructure, because I think it will leverage the workforce. It will put everyone top of license and at the most efficient point of their profession.
That's wonderful news. And I'm hearing lots of things in terms of it saves time. Of course, it obviously saves money, which we're all looking at ways for hospitals to be able to run more efficiently from a numbers perspective. And it sounds like it probably has some positive effects, I imagine, on patient care.
Absolutely.
What about the staff? How are we seeing it's affecting those who are in the profession, whether they're fairly new or if they're quite seasoned, or perhaps those who are entering in the profession? Do we see any effects from that standpoint? I don't know if someone wants to volunteer on that one.
I think that for sure the whole AI movement is alive and well at universities, and in terms of developing strategies for students to be more successful in seeking their major. It is also the case that most large hospital HR systems that have electronic medical record have some built-in AI already. And what is often the case is that the nurses, or in my case, nursing students, are not fully aware of as how embedded those things are. So I think it's our responsibility to not only promote this as a cost as well as enhancement to patient care, but also to help nurses understand that this is active, and nurses need to be participants and partners in development of AI strategies.
Judy, I'd just like to emphasize that in most of the organizations with which I work, we really have nursing teams that work with the IT people in order to do exactly what you said. And it's so important. Otherwise, IT can sit over there and think these things need to go together, but they don't. from a clinical perspective. So our advice, I think, as a group here, and what I'm hearing you say too, Judy, is make sure that nursing is part of the decision-making process and the design process.
Absolutely, it makes a lot of sense. Now, I'm curious, how do you foresee this affecting staffing ratios? Because I know it's a hot button in some states more than others. And Donna, what's the standpoint of Arizona when it comes to staffing ratios? Because I know it can vary from state to state. Is that something that's kind of regulated by the state? Is it they kind of leave it up to the judgment of the facility? How does it work there?
Yeah, there are so many variables that go into staffing and staffing ratios that we leave it up to the facilities. They know the competencies of their nurses. They know the patient demographics. They know the skill set of their, ancillary personnel, their resources, both internal and external. So we leave it up to the individual organizations to make those determinations for safe staffing.
Okay, makes sense. So with that being said, how do you see, or would anyone like to predict what they see in the future of how it could affect staffing ratios? I mean, some things I hear across the nation, maybe 1 to 2, 1 to 1 on ICU, but maybe med-surg might be 1 in 6, perhaps even a little bit more when the staffing ratios are higher in terms of the census. Do you see that moving the needle on any one of those areas within certain departments, and if so, which departments do you see it affecting the most? Julie, I don't know if you had a comment on that, and if any others want to chime in on that.
If you look at a lot of the literature and really look at how much time the nurse spends in the computer as opposed to with the patient, I mean, depending on the literature you're sourcing, maybe 60% of their time is with the computer and 30 to 40% is with the patient. It could be variability on those numbers, but we really want to develop the intelligence of what we take forward to really give time back to the nurse to give to the patient at the bedside. And I think when we start to talk like that, it does promote the nurse to be more at top of license, because you're mining data, you're doing things that make it easier for the nurse to do her work. The facility I'm at now, not unlike many, we have cameras in the rooms to observe patients to try to prevent falls or things like that. So all those pieces and parts can make a difference in the time, one, the nurse can give the patient, and two, the time they may be able to give to another patient. Really just putting the idea of top of license back to the nurse and really getting the best from the intelligence that they bring to the table with their registered nursing degree.
Absolutely. No, I appreciate that. Okay, so as we round out this hour, and I know some of ours was taken by technology, but I'm just so happy that all of you were able to come back today. I want to get just kind of individual thoughts, any tidbits of wisdom you'd like to share with facilities on what they should be focusing on now when it comes to either virtual care, AI, or both as it relates to nursing. And so, perhaps let's say Dr. Karshmer, let's start off with you, and then we'll go Dr. Cato, and then Dr. Anderson and Julie will let you finish us out. How about that?
Great.
So I think sort of central to our conversation today is that the center of these decisions really need be the patient and their family. So using a remote monitoring, using that kind of telehealth opportunities is really something that we need to always have a conversation with our patients and their families. What's the best way? It doesn't have to be the most tacky way. It may be just you need to step on your scale once a day and call your nurse. The other thing is, I think when we think about the power of artificial intelligence, that we need to be able to help people not be afraid of it, and that it is in fact something that's going to propel us forward and to provide better and better, safer care. Again, always with the patient and the family at the center of that.
Very good. And then how about you, Dr. Cato?
I would segue off of what Dr. Karshmer say. I think that we need to embrace technology. It's not going to go away. And we just become leaders in this area, step up, step out, be at the table, help with those decision makings, help our colleagues understand how this is enfolded into the care that we deliver each and every day, regardless of what practice setting we're in. So just thinking about the future and how we can be a part of the future and not be along for the ride for the future.
Okay, very good. And then how about you, Dr. Anderson?
Over the years, we've had all different types of models of care. We've had primary nursing, we've had team nursing, we've had all different types of nursing care models. And I say this is a new model. And we need to embrace, as my colleague said, the use of technology as part of that model. But do it with the patient, as was stated, and really use, and this is what I did when I was with children's hospitals, is have patient advisory groups that help us design that model of care. They helped us design the way the building would be built. And I would suggest that a new model of care with technology as part of the model of care, with patients helping guide what that model is going to look like and be like in their particular organization, would be really a key way to begin looking at this.
Excellent. Thank you very much. And then also, Julie, Ms. Bowman, can you finish us out?
Sky's the limit. Technology is endless. We have to use the technology, but not lose the patient, and really keeping the patient and the family at the center of what we do. Doesn't mean we can't embrace technology and lean in on how we can take more technology forward, but with academic partners, with technical partners, all of this is possible. Again, the sky's the limit.
Awesome. Well, I really appreciate having all of you on today, and I really appreciate your patience throughout these issues we had today. And what we're going to do, folks, those who are watching in any one of these areas, what we're going to do is we're going to actually splice them all together into one nice program, and then we're going to re-upload that probably to YouTube, because LinkedIn has some limitations on how long you can upload something. It's 10 minutes, I think, is the limit for LinkedIn. So we'll upload it so others can actually view this. And definitely appreciate all of you being on the program today. It's been a pleasure. Definitely want to have you guys back. We'll see how things go, how things progress over the next several months. See what the next several months bring us in terms of how we are incorporating virtual care and AI into nursing. So let's say bye to everyone, and we'll ask you guys to stand for just a second before we close out. So bye, everyone.
Bye-bye.
Bye.
Bye.
Thank you for having us.
Thank you for being here. Really, really appreciate